No question.
Do you have any questions?
Maybe one question to Professor Thomas End regarding para-aortic lymphadenectomy. Do you understand clearly that you are not more performing the procedure of para-aortic lymphadenectomy in your institute? Am I right?
I was trying to be controversial. I do generally at this meeting give one controversial talk, and I was trying to be thought-provoking. I think, of course we do para-aortic lymphadenectomies, but, often we go after large, big pelvic nodes, like the one you saw on the video. The sort of systematic stripping, sort of nudity of the IVC and the aorta, you really do have to think very carefully about, because there's no evidence that it improves survival in anything. Obviously, nodes with disease should be removed in ovary cancer. Nodes that are sentinel nodes, and obviously, as you know, when we're doing these sentinel node dissections now, we do often see tracts coming up the presacral tract up towards the para-aortic area. But I think the sort of systematic stripping of nodes has to be reflected on quite carefully, because there doesn't seem to be any value in it, any proven value. They're obviously the exception to prove the rule. And I don't think I love surgery. I do it for a living. I love that particular type of surgery because you can show off at meetings. It's got a little bit of Y factor, and you can video it. But actually, I'm not too sure it is of any benefit. I can see Rob is laughing. So maybe we can hear Ahmed's laughing too now. Maybe you could cross it over to the floor to those who don't need to go to prayer. I don't know.
As a matter of sharing experience, we reduced the number of para-aortic lymphadenectomy in our institute in the last 2 or 3 years after the Lion study at the end of 2017, because we think that it will be more safer for the patient, or less complication and less stressful situation for everybody. Okay, any more questions?
Yes, I have a question for Professor Saeed Abdelhadi. Is there any role for PET scan in the diagnosis of these ovarian tumors in children and young adults?
Fortunately enough, most tumors in children and young adults are of the germ cell subtype, usually in early stage, and also of low-grade malignancy. So, as I said in the presentation, we usually go with ultrasound if suspicious, then for the MRI, and in both cases, we will add the tumor markers. PET scan will come perhaps later on if we do surgery and find it is advanced. Then we can follow up by PET scan. But to the best of my knowledge, we don't include the PET scan in the first go for the assessment or for the follow-up of these patients.
And the size of the swelling when it is less than 8 centimeters, your limit for intervention is 8 centimeters for follow-up, or it is not a little bit large, 8 centimeters?
All right. Perhaps the literature changes that one. We used to say a cutoff value of 7 or 8 centimeters, but now more significant than is the size is the other characters. If it is a thin wall, if it is a clear content, perhaps there is no multilocularity, there is no bilaterality, there is no papillae. So the size alone doesn't make huge difference. And even there are reports if it's a big but thin wall, clear content, that's an adenoma simplex that doesn't need more. Also, in this young age group in children and young adults, it's better not to intervene unless you have done the whole components. So you go with the clinical presentation, you go with the ultrasound. Perhaps now there are reports of about a PR or transrectal ultrasound. But anyhow, the abdominal one can give good data, especially if it is big size, and then the MRI, and then the tumor markers. But there is advice now not to play hard with this unless you have objective evidence conclusive that you might find a borderline or a malignant one. But the simple one, even if it's 7 to 8 centimeters, just follow up.
Okay. And for the frozen section, you can change your decision upon the findings of a frozen section during the operation, or you have, is that of value to do frozen section during the surgery?
Yeah, that's a very important point. Probably the colleagues from the UK don't trust too much in the frozen section, and they plan all the management based on their operative assessment and the proper hematoxin and AEC. But in our experience, and I would thank the pathologists in our center, they were very good in difference between them. It was called the CAPA agreement between the pathologists trying to say borderline or malignant or benign. The discrimination was very good between the malignant and the benign. We didn't get any confusion in this area. The agreement for the borderline was a bit less, and this is probably now, in our experience in our center, the most difficult is the borderline. Probably they would 50% say it is malignant, or in the other 50% they would say it is probably benign. But the crystal clear malignancy, 100% comes as malignant by the proper pathology, and that's good. So we'll end up with the borderline, which is again over 95% will come as of good prognosis. So you will still get good data from the frozen section, and this is why we are carrying on. We are expanding our team for the pathologist, and we are now confident in their assessment, especially if it is clear-cut, malignant, or benign. The borderline sometimes varies, but adding to that the good prognosis of the borderline, so I would say, yes, we still rely on the frozen section in our institute.
Thank you. Thank you.
Before we leave, Thomas, would you add, because I know you do no longer rely, but in our experience, we think it is helpful. Do you agree or disagree for that one?
My fellows are currently operating on a 38-year-old lady with bilateral complex ovarian masses and a CA125 of 158.
Yeah, good.
She's got an umbilical hernia and her BMI is 65.
Fine.
She wants to preserve her fertility. I'm not a fan of frozen section, but I'm telling you, I'm waiting on her results and with great anticipation as we speak.
Good.
And of course, there's a role for everything. But, you know, we've got a problem with ITU beds today because we're in London. Our histopathologists don't believe in working after 5 o'clock. So, you know, we have to put her first on the list. If we don't get another ITU bed, we can't do our second case. You know, lots of problems with frozen section when one puts in practicalities. But, yes,
I agree.
I'm not a great fan of it, but a place in certain cases.
Yeah, my good days back in Manchester, they have very good pathologists, world class, you know, Professor Fox and Buckley at that time they were working in, and yet they couldn't get agreement more than 70 to 80%. So 20 years back it was confusing, now it is as well confusing, but in our experience it can give you good answer for the clear malignant and clear benign. In the borderline cases, you would be able to come back by laparoscopy or so and remove the adnexum if it is affected. But we still believe it can help. Okay? Yeah. Any further questions you would ask me? Or
As now, thank you very much for the speaker. Thank you for all audience, and we'll see you later.
Thank you very much. Thank you for our speakers, and we will see you in the last session in an hour time or so. Thanks. Bye-bye. Bye, Ahmed. Nice to see you. Goodbye.
Bye.
Bye-bye for everybody.